طيب بسم الله، مبتدئ دكتور محمد.
بسم الله الرحمن الرحيم. بسم الله والصلاة والسلام على رسول الله. First of all, I want to thank all of participants for attending this webinar, and this is the third webinar. And to thank Dr. Dhafir for his support, and also Dr. Muhaidib and Dr. Muad for sure as president of SASBGAN. First of all, and for sure to thank all speakers that will be with us today, inshallah. And it will be very nice and very informative informations will be taken from these lectures, inshallah. First speaker will start with Prof. Abdullah Al-Angiri. Prof. Abdullah Al-Angiri, he's a professor of pediatrics. University. Also, Prof. Abdullah, he is the president of Saudi Arabia Asthma and Immunology Society. He has many a reviewer for many journals, a lot of publications in distinguished journals. He was graduated for sure a long time ago, mashallah tabarakallah, from Harvard Medical School. Prof. Abdullah, the mic is for you, please.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Muhammad, for your kind introduction. And I thank the organizers of this symposium for giving me the opportunity to speak, and the Saudi Society of Pediatric Gastroenterology, Hepatology and Nutrition for also their kind invitation. Okay. So, as you know, my talk today would be about primary immune deficiency diseases and how to approach them. They are also called inborn errors of immunity. This is the more recent terminology that is adopted. So first of all, let me just give a very quick introduction about, the major divisions of the immune system. To start with, the immune system is divided, just for simplicity of explanation, into innate and adaptive. By innate, we mean non-specific immune response that includes barriers like the skin, secretions, mucociliary clearance, phagocytes like neutrophils, macrophages, complement, and cytokines. The cells involved in this part in the innate system would not differentiate between specific, molecules or antigens. They respond in a similar way to groups of, let's say, antigens or organisms. On the other hand, the specific or so-called also adaptive immune system is subdivided further into a humoral and cellular systems. The humoral is a function of the B lymphocytes, which is composed of immunoglobulins, basically, mainly. And the cellular system is mainly the function of T lymphocytes. This is just in very simple terms. The differences between the humoral and cell-mediated immunity in different ways. We mentioned the cell types and that the immune system is mainly a function of immunoglobulins, while the cell-mediated immunity is the function of T cells and the cells activated by them. The cell-mediated immunity is further subdivided in very general terms into T helper cells and cytolytic or cytotoxic T lymphocytes. The T helper cells will augment the phagocytic cells to kill the ingested microbes and while the cytolytic cells will help lyse infected cells, especially in defense against viruses, so preventing the the media for proliferation. This is in very just general terms. The main differences between the humoral, the innate and adaptive immune system are in two major things. One thing is specificity, as I mentioned, and that the cellular immune system can differentiate between different antigens or even parts of antigens. And the other difference is memory, and that is the adaptive immune system can remember previous exposures, and this is basically the main idea behind vaccines. So this graph just gives an example that if you inject, let's say, a mouse with antigen X, there will be a response by producing immunoglobulins within a couple of weeks, and this will peak and then come down. And if you inject the same mouse with the same antigen X and a different antigen Y, you will have an exaggerated response to the first antigen X, which will last longer, while the response to antigen Y would be just as a new antigen. So the system can differentiate the two antigens. This is specificity, and can remember previous exposure, which is memory. So having this in mind, just go straight to the definition of immune deficiency. And immune deficiency represents a diverse group of abnormalities of the immune system, resulting primarily in an increased susceptibility to infection. So this is the hallmark of when we say immunodeficiency, and it is either primary, which is inherited or congenital, or secondary, or which is acquired, which could be transient or permanent. Now, the focus of this talk would be about primary immune deficiencies. And primary immune deficiency can affect any line of the immune system. Worldwide, antibody deficiencies are the most common. Then cell-mediated immune deficiency or combined immune deficiency, because defects affecting the T cells will eventually indirectly affect B cell function, but the reverse is not true. Also, phagocytes can be affected or complement. Primary immune deficiencies is more common than many people would think. It is, in our societies, probably more than 1 in 1,000. So we have, it's more common in our societies compared to many in the West, for example. So, as I said, most common presentation of primary immune deficiency are recurrent infections. And we have to remember that not all recurrent infections indicate immune deficiencies. Sometimes there is an anatomical defect, for example, a functional defect of the organ itself, like, for example, cystic fibrosis or ciliary dyskinesia with recurrent pulmonary infection. H-type TE fistula cause recurrent chest infection, or vesicular reflux cause recurrent UTI. And also, we need to remember that many primary deficiencies are complicated by autoimmunity, autoinflammation, and malignancy, as you will hear from my colleagues afterward. Careful history and physical examination remains the most important will give the most important clue to the diagnosis and will direct investigations. So let me talk just briefly and quickly about specific defects affecting different lines of the immune system with a few examples. First of all, complement deficiencies can affect either the early if we take classic pathway as an example, it can affect the early pathway, including C14-213, leading to presentation with pyogenic infections and autoimmunity, mainly lupus-like illnesses, vasculitis, and defects affecting late complement system from C5 to 9, called the membrane attack complex, will usually present with recurrent or disseminated Neisseria infections. Defects affecting phagocytes may affect different, functions of the phagocytes, or it may affect the phagocytic numbers presented with cyclic neutropenia or severe congenital neutropenia. It may affect the ability of leukocytes or phagocytes to adhere to the blood vessel wall, capillary wall, presenting, like, for example, leukocyte adhesion defects. Defects may also affect the process of chemotaxis, which is the controls the migration of phagocytes from the blood vascular component into the affected tissue, like what happened, for example, in Ige Syndrome, and disorders may affect intracellular killing, bacterial intracellular killing, and the classic example of this is chronic granulomatous disease. And let me just briefly mention some couple of things about chronic granulomatous disease, because you hear a lot about it, especially in children. When you talk about very early onset inflammatory bowel disease, one of the things that one needs to rule out is chronic granulomatous disease, as it may present in a similar way. Basically, this disease results from a defect in NADPH oxidase enzyme, which leads to failure of production of oxygen radicals, and therefore these are oxygen radicals, and which are utilized to form hydrogen peroxide, and then further converted into hypochlorous acid, these are all toxic to the cells and bacteria. They are all produced within vesicles, so the cell is protected. But the most toxic one is this, the HOCl. Therefore, the cell will not be able to kill the ingested bacteria. This is said to affect mainly or result in mast infections with catalase-positive bacteria and fungi, because these organisms lack, because of they produce catalase, which destroys H2O2 produced by the same organism that in some situations the cell itself would use H2O2 to convert it to the most toxic material here, because this enzyme is intact, myeloperoxidase, to kill the same bacteria. So patients will present with recurrent pneumonia, deep-seated abscesses due to organisms mainly Staph aureus, Serratia, B. cepacia, and fungi mainly Aspergillus and other organisms. Aspergillus is the most common cause of death in those patients. It can be inherited as X-linked or autosomal recessive, depending on which component of the NADPH oxidase is affected. The GB91 is encoded in the X chromosome, while the others, each one is encoded in a different autosome. Diagnosed by now, the classic method is by oxidative versus, say, by flow cytometry. And patients, most of them nowadays, would require bone marrow transplantation, and they need to be put on Bactrim and itraconazole prophylaxis in the interim. Defects in T-cell immunity usually presents very early in life, usually in the first 5 months of age. and are associated usually with infections with diverse group of organisms, including fungal, viral, mycobacterial pathogens. Patients may develop also infections with opportunistic organisms like Pneumocystis jirovecii. So these are clues of T cell defects, like, for example, Pneumocystis jirovecii, or opportunistic organisms like CMV, and some fungi should raise the possibility of T cell defect. The patient also will have severe failure to thrive, and they may also present with graft versus host disease secondary to blood product transfusion, because the blood product packed RBCs will contain some white cells, or that's therefore those patients should only receive irradiated packed RBCs to kill or to eliminate white cells. Or it may happen secondary to in utero maternal fetal transfusion. As I said, this is often associated with B cell defect because of lack of T cell help. The causes of defects in T cells immunity are either acquired or congenital. Acquired, worldwide, the most common cause is severe malnutrition. Also, patients who are on immunosuppressive drugs or receiving radiation, radiotherapy, for example, or exposed to high levels of radiation, or of course infections, especially like HIV. Okay, congenital, the most severe form is called severe combined immunodeficiency syndrome, SCID. It's usually characterized by marked lymphopenia. Usually the total T cell, total lymphocyte count would be low, but more importantly, T cells themselves would be low. CD3 count would be less than, usually less than 300 by definition. Lymphopenia in neonates should also raise suspicion of T cell deficiency less than 2,000 and warrants investigation, even if the neonate looks and behaves completely normally. It's regarded as a pediatric emergency because of the importance of early intervention, recognition to prevent complication, and because also that early bone marrow transplantation before severe infections develop makes a huge difference in survival, in disease-free survival. So it can reach to 95% as compared to less than 80% if done later, especially after, when severe infections developed, which is usually this, happens most of the time after 3 months. There's newborn screening now for severe combined immunodeficiency that can be done together with the metabolic screening using the same old Guthrie cards to look for, the test is called T-Rex, T cell excision circles, and which results from the development of T cell receptors in the thymus. So the presence of these circles would indicate active proliferation and production of naive T cells, which, and then the lack of them would typically happen in patients with SCID and some other combined immune deficiency as well will have defect in or will have positive test. It's not currently available in the kingdom, but hopefully it will be available in the future. The other form of T cell defect is combined immune deficiency. So again, combined T and B cell defect, but it doesn't fit the definition of SCID, but it may behave clinically very similar to SCID. The main difference is that the T cell number is not low. There are many tens of examples that in this category. Famous examples like Wiskott-Aldrich syndrome, ataxia telangiectasia, Ige syndrome, and many others. There are, currently in general more than 450 different genetic defects in the immune system that may be associated with inborn errors of immunity. Now let's move to defects in B cells. They usually start or typically starts after 6 months of age, because the child would be protected in the first few months by the maternal IgG. The patients usually would have recurrent infection with encapsulated organisms and usually develop or present with chronic sinusitis, otitis, and pneumonia. They may also develop recurrent sepsis, meningitis, or osteomyelitis. So again, a broad range of infections, but they don't usually have much problem with fungi or viruses, except enteroviruses and polio virus. And they, of course, because they're less severe, they don't have as much growth failure. So, defects in T or B cell immunity may present, as you'll hear from my colleagues later, as very early onset inflammatory bowel disease. So, deficiencies of B cell immunity, there are so many defects that can lead to this, including the classic prototypic example is X-linked agammaglobulinemia, which is a Proton's disease, autosomal recessive agammaglobulinemia, common variable immune deficiency, CVID, which is hypogammaglobulinemia with poor antibody responses to antigens, and hyper-Igm syndromes, characterized by high or normal IgM with low IgG and IgA. There is because they have a defect in class switching from IgM to other isotypes. Hyper-IgE syndromes is also another group of defects affecting B cells, and also may affect other cells depending on the type of hyper-IgE syndrome. Usually IgE would be more than 1,000 associated with significant recurrent infections. But remember that most children with high IgE, more than 1,000 international per mil, do not in fact have primary immunodeficiency. Many of them have things like atopic dermatitis or other atopic conditions. This, as I said, it's a group of diseases that may be inherited as autosomal dominant, recessive, or X-linked with variable phenotypes. The classic example is autosomal dominant hyper-IgE syndrome secondary to mutation in STAT3, which is called also Job syndrome. As I said, it could be associated with B cell, T cell, or innate immune defects, and the management would depend on the cause. So, having just very general overview of the immune system and defects that may affect different lines of the immune system, how should we approach a child with suspected immunodeficiency? As I said earlier, history and physical examination will give the most important clues. The age of onset is important, as discussed. Family history also very critical. Consanguinity, for example, between parents and other family history, like close family history or distant relatives affected. with history of immunodeficiency, the site of infection, the nature of infectious microbes, and also one important thing is adverse reactions to live attenuated vaccine can be an important clue. In terms of physical examination, this is, by the way, there are people who develop this 10 warning signs of primary immunodeficiency diseases that are, developed by convention, not, they don't stand on solid, scientific grounds, but they can be useful for the general physician. For example, in deciding what patients to investigate. For example, development of 4 or more new ear infections within 1 year, especially in toddlers, 2 or more serious sinus infections, or 2 or more pneumonias per year, or requirement of IV antibiotics for infections that usually do not, or prolonged period of therapy, deep abscesses, or not, persistent oral thrush or recurrent oral thrush, and as I said, family history. So these are important clues. In terms of examination, things to pay attention to: absent tonsils may indicate B-cell defects, if the patient, of course, did not have tonsillectomy. Absent lymph nodes may indicate combined TB cell defect. On the other hand, lymph node hyperplasia may also be associated with immune defects like CVID or CGD. Absent BCG scar may give a clue for T-cell defect, but it would not rule them. The presence of BCG scar will not rule them out. Delayed separation of the umbilical cord may suggest leukocyte adhesion defects. So these are some tips related to physical examination. In terms of investigation, the initial investigation that we should not forget is CBC differential. We should look at the white cell count, neutrophil count, and for our purposes, very importantly, lymphocyte count, which is frequently overlooked. Also, other parameters of the CBC are important. Quantitative immunoglobulin levels, so IgG, M, and E are widely available in many places, and good screening tool. Chest X-ray for thymic shadow may be useful in newborns to look for the thymus. This is a lateral film of a newborn. We see here, the retrosternal thymic shadow is absent, suggesting thymic aplasia. There are specific investigations directed towards the suspected type of immune defect. For example, as I said, for CGD, oxidative burst complement, if you look for the classical pathway, CH50, for alternative pathway, AH50. This is just a functional assay to look for the function of the whole pathway, the complement. Flow cytometry for adhesion molecules. There are specific lists to look for chemotactic function. In terms of humoral components, checking specific antibody responses to vaccines like tetanus, pneumococcal influenza, and pneumococcus, looking for response to protein and polysaccharides. Antigen, isohemagglutinins, also antibody against the blood groups, which are usually IgM antibodies. And IgG subclasses sometimes are useful, although most of the time they are not very informative. Cellular components, looking for T cell subsets, CD3 T cells, CD4, CD3, CD4 positive helper cells, cytolytic T cells, CD8 positive, B cells, CD19 or 20, and NK cells, 1656. T cell function, delayed skin hypersensitivity reaction to intradermal candida and tetanus used to be used, but nowadays they are not much used, and we don't have reagents also available in the market. But the gold standard is lymphocyte proliferation assays in vitro, and don't forget about HIV testing. The third final stage is next generation sequencing, looking for genetic defects in known genes known to cause inborn error of immunity, or if they're none, looking for defects in the whole exome, which are, of course, as you know, widely also used to look for inherited defects in or diseases affecting the GI system or any other system. Just a couple of words about IVIG used in the treatment of antibody deficiency hypogammaglobulinemia. They are basically human IgG prepared from pooled plasma of thousands of donors, usually more than 10,000 donors, and it's used to treat as a replacement therapy for patients who have hypogammaglobulinemia. Can be used either IV or subcutaneously, and the trough level should be monitored, until we reach satisfactory level. Usually, it's a very safe treatment, but adverse effects, may happen. Usually, non-specific generalized reactions are the most common. So mild reactions like flushing, headache, backache, chills, myalgia, nausea. In this case, intervention by slow infusion and treat the symptoms. If the patient develops urticaria, bronchospasm, vomiting, these are rare, then stop the infusion and treat the symptoms and revise. Anaphylaxis is extremely rare, but it could happen. In terms of, there are also some organ-specific or idiosyncratic reactions which are rare. The risk of disease transmission is negligible because it's specifically treated in multiple steps to eliminate, organisms and different viruses. But we should pay attention to this theoretical risk in general. So thank you very much for listening, and thank you again for inviting me.
Thank you, Prof. Abdullah, on the time, and very informative to me, to all, for pediatric gastroenterologist, pediatrician, general practitioner, for this holistic approach and basics in very limited time. And also we have
دكتور محمد، الصوت ما هو واضح. دكتور محمد. دكتور محمد. دكتور محمد، الصوت غير واضح، انقطع صوتك. طيب، ربما في مشكلة عند الدكتور محمد.
اوكي دكتور ظافر،
تفضل دكتور.
maybe you can. السلام عليكم ورحمة الله وبركاته. We can introduce Professor Salih Al-Muhsin, I think now.
Yes.
Just for the time. If the questions will be in the end, we can proceed to Prof. Salih Al-Muhsin now. Maybe Dr. Muhammad has problem in his, signals or in the net.
Okay. So the second speaker will be Prof. Salih Al-Muhsin. He's a Prof of Pediatrics and Allergy Immunology Consultant at King Saud University Medical City, and also at King Faisal Specialist Hospital and Research Center in Riyadh. Prof. Salih is well-known figure in, and he has good publications, especially in GI manifestations of primary immune deficiency. Welcome, Dr. Salih, and we'd like to thank you for this nice accepting invitations, and the mic is yours now.
Thank you, Dr. Muad, and thanks for the organizer for their kind invitation. For sake of time, I would go and share my slide. So I think Dr. Abdullah or Professor Abdullah had made my mission is easier by that great overview of what he has presented. So what I'll be covering now is the more specific into gastrointestinal manifestation of a patient with primary immune deficiency. So as you know, as Abdullah have elaborated very clearly, that the inborn error of immunity or primary immune deficiency are a group of diseases with genetic mechanism and gender underlying cause, and they usually manifest with three types of manifestation. I'm mentioning this three types of manifestation because most of the GI manifestation and complication are arising from one of these mechanisms. Either it comes from infection or autoimmune disease, or sometimes from dysregulated inflammation that can predispose to malignancies. As Abdullah mentioned, there is clearly increase in the prevalence and diagnosis of patient with primary immune deficiency, especially in our region. And this is being across the board for all type of genetic driven primary immune deficiency. Why is it more prevalent in Saudi Arabia? Because we have high risk of, because we have high incidence of consanguinity that's reaching up to more than 50%. And improving diagnosis and diagnosis modalities had improved the early diagnosis and then managing those patients early. Definitely awareness is important. That's why I think this session has been conducted to disseminate the knowledge and awareness among gastroenterologists and people in gastroenterology field about how patients with primary immune deficiency can present from their perspective. We have conducted a review and looking at different type of ethnic groups, and you can see that most the second common manifestation of patients with primary immune deficiency, as you can see in the second column on the left side, is diarrhea. So therefore, it is quite significant to see in your clinic, patient comes in with immune deficiency either as the primary and leading symptom, or sometimes with known diagnosis and then being referred to you for helping to manage those patients. So looking at patients with primary immune deficiency in general, how can their GI manifestation present that can be arising from many different mechanisms that have been summarized in this infographic into 5 types of modality or mechanism. The first and the most common is infection. And the example for those that have been covered again with Professor Abdullah, giardiasis in patients with immune deficiency, CMV colitis and hepatitis in patients with severe combined immune deficiency, and also hepatic abscesses in patients with chronic granulomatous diseases. The other manifestation patients present with are autoimmunity, and the example for those type of manifestation like autoimmune hepatitis and enteropathy in certain group of patients, mainly humoral immune deficiency. Many other patients can present with unregulated inflammation, as has been elaborated clearly that, for example, patients with CGD can present with granulomatous colitis. The fourth manifestation patient might present with that unregulated inflammation cells can cause malignancy. And the example for this type of manifestation is lymphoma in patients with XLP and Wiskott-Aldrich syndrome. Lastly, patient might present with complication of therapy. For example, patients who undergo hematobiotic stem cell transplantation for severe combined immune deficiency might present with severe colitis or severe hepatitis that can cause, definitely clearly that people from gastroenterology will be, our colleague from gastroenterology will be more than helpful to help us in managing those patients. The other manifestation, again, in patients with hematobiotic stem cell transplantation for severe combined immune deficiency can present with phenol-occlusive disease of the liver. And this is, again, another way of patient manifesting as gastrointestinal and hepatic disease. This table, although it's busy, but it summarizes the different type of GI manifestation, GI and the hepatic manifestation among different type or group of primary immune deficiency. If you allow me, I might spend a few minutes in trying to describe, because that might be paving the way and making the rest of the presentation can be summarized and easily. For junior trainees and junior attendees from the audience, I would recommend that you can look at this table and can share this presentation with you. And this really can summarize most of the manifestation that we do see a patient with primary immune deficiency. As you can see here, for example, patient with combined T and B cell immune deficiency with, for example, severe combined immune deficiency can present with colitis, hepatitis secondary to infection, mainly CMV, but also can present with candidiasis, like esophageal candidiasis, chronic diarrhea, and as I mentioned, graft versus host disease. One phenotype of severe combined immune deficiency called Almond Syndrome, where patient can present with hepatosplenomegaly. Diarrhea is a common feature of their presentation. And they can, if you do a biopsy on those patients, you can find eosinophilic enteropathy. A patient with ADA deficiency can present with autoimmune hepatitis and diarrhea, MHC class 2 deficiency, Bell lymphocyte syndrome. The very significant manifestation that they are presenting with are protracted, profuse diarrhea, mainly secondary to cryptosporidium. Also, they can present with progressive liver disease. Patient with Igm, common manifestation that they present with sclerosing cholangitis, but also can present with oral ulcer secondary to neutropenia. They can present with diarrhea secondary to cryptosporidium infection. The other category of patients with primary immune deficiency, like predominantly antibody or humoral immune deficiency, like selective IgA deficiency, they can present with infectious manifestation, mainly to Giardia and enteroviruses, presenting with diarrhea. But also they can present with non-infectious manifestation like celiac spoo, nodular lymphoid hyperplasia. The other type of disease like X-linked AGAM and common variable immune deficiency, they are more severe phenotype, and they can present with more profound feature of GI manifestation, like chronic diarrhea, malabsorption, again, giardial infection, nodular lymphoid hyperplasia, villus planting, IBD like colitis, as well as also pernicious anemia. They are also at risk of developing malignancies. Patient with well-defined immune deficiency like Wiskott-Aldrich can present with colitis, bloody diarrhea, eosinophilic enteropathy, and lymphoma. Patient with Ige syndrome can present with liver abscesses, periodontitis, eosinophilic enteropathy. Patient with chronic mucocutaneous candidiasis, definitely as per definition, can present with severe esophageal candidiasis. As mentioned, hepatic venous disease with immune deficiency, which is post-transplantation. They can present with obstructive type of vein-occlusive disease. A special type of what we call very early onset IBD, like for example, being found in patients with IPEX, which is a disease of immune dysregulation that patients present with severe enteropathy, diarrhea, malabsorption, and failure to thrive. Again, a patient also with Heminis-Bodlak syndrome. They can present with colitis. Patients with XLP can present with fulminant hepatic failure secondary to EBV infection, or even can predispose to lymphoma. Patient with disease of phagocyte, the very typical disease example is chronic granulomatous disease. And the profile of GI manifestation is quite significant. Oral ulcer, esophageal dysmotility, gastric obstruction, and also small bowel obstruction, colitis, perianal fistula, hepatitis, liver abscesses. Other manifestation, other disease like leukocyte adhesion defect can present with infection, mainly ampulitis and periodontitis. Schwachman-Diamond syndrome, as you know, that can cause pancreatic enzyme insufficiency with malabsorption. Specific type of immune deficiency with interferon gamma IL-12, they can present with salmonella gastroenteritis and malabsorption. Patient with hereditary angioedema is very also it's part of the primary immune deficiency profile, and the patient can present with severe complication of severe abdominal pain because of this intestinal wall edema. Again, this table can summarize most of the disease phenotype and the GI manifestation that patient might present with. Now let us take some of the examples that have been covered by Professor Abdullah, but I'd like to shed light on the GI manifestation of those type of deficiency. The common type of immunodeficiency, we see it in Saudi Arabia because of high consanguinity, is severe combined immunodeficiency. Patient might present with different type and profile and spectrum of manifestation, including infectious and non-infectious. But for the infectious, definitely that patient can present with severe diarrhea, chronic and also severe hepatitis secondary to CMV or EBV related disease. Patient can present also with oral thrush and candidiasis. Other non-GI manifestation, for example, failure to thrive. Chronic diarrhea sometimes is not related to infectious cause, necessarily maybe not related, and it is defected in the cellular mechanism. Some of the phenotype can present with GVHD-like manifestation, and I'll mention one of the examples. Definitely, there are infectious causes can contribute to this type of manifestation, including CMV and Candida, plus also EBV, as well as also other type of bacterial and viral infection. One of the phenotypes can present with a specific and typical feature of GVHD-like manifestation with very severe xenophilic gastroenteritis and sometimes even hepatitis, which is called Almond Syndrome. Different type of genetic cause can predispose to this type of disease, but commonly RAG1 and RAG2 deficiency. The other disease phenotype or group of diseases is phagocytic disorder. Among them is chronic granulomatous disease. As been mentioned by Professor Abdullah, that there is problem in the phagocytic oxidase mechanism, which can help in carrying the free radicals to carrying the electron to be able to generate free radicals, which can contribute to the killing of mechanism of the bacteria. If this enzyme is defective, then you'll end up by poor killing, and therefore sometimes you will end up by either predisposition to infection or granuloma formation, as you can see, and good number of patients can present with inflammatory bowel disease. There are again infectious and non-infectious complication of that disease. The infectious complication mainly liver abscesses, but also can present with non-infectious manifestation like granuloma. 20% or 25% of patients can present with inflammatory bowel disease like manifestation. Different type of organism can contribute to this type of infection, but definitely Burkholderia cepacia and Staphylococcus among the common organism. We do see a patient with liver abscess can be isolated from. If we summarize the GI and hepatic manifestation in patients with CGD, it can look into, for example, proximal GIT tract. They can present with oral ulcer, dental abscesses, oral candidiasis, granulomatous inflammation, even in the upper GI, leading to stricture formation and obstruction. Eosinophilic gastritis. For the intestine and colon manifestation, they can present as granulomatous colitis, which is specific and distinct feature that might be similar to Crohn's, but not really completely similar to it. Patient might present with obstruction, stenosis, and fistula. The CGD colitis might be the leading symptom. So good number of patients that can present as early diagnosis of colitis, early diagnosis of CGD by colitis, and they have seen many patients who present initially as severe bloody diarrhea and end up to be diagnosed as CGD patients. It is difficult to differentiate, however, with good history and physical examination, that you will be able to differentiate between a patient with Crohn's disease and CGD. For the manifestation related to distal GI tract, you can see, for example, infection in the perianal gland that can lead to fistula in ano, and probably it is due to ineffective clearance of bacteria in patients with CGD, and also patient might present with rectal granulomatous inflammation. For liver manifestation, patient can present with transient hepatitis, liver abscesses that might be correlated with high mortality. The most common cause of patients with liver abscesses are Staph aureus, Burkholderia cepacia, But also patient might manifest with drug-related hepatotoxicity, knowing that some of the prophylactic medication that we use for those patients, like for example, antifungal and antimicrobial, that can be causing liver toxicity. A growth delay is another significant manifestation of patients with CGD and can cause failure to thrive. Patients with GI manifestation among CGD patients are prone to have more growth delay than the other ones. Might be related to the malabsorption or the cellular mechanism of the disease itself. Here is the endoscopic finding and colonoscopic finding of patients with mucosal inflammation, erythema, edema in patients with CGD, and you are in better position actually to describe it. Again, here is the histopathological finding for patients with CGD. And you can see that there is chronic inflammation, there is a distortion of the architecture of the colon, and the high power field shows the granuloma very clearly. You can see it here. The other group entity, which is humoral immune deficiency, like A gamma and common variable immune deficiency. A patient might present with manifestation related to infection and non-infectious. As mentioned before, the infectious, for example, Giardia and enterovirus might cause significant severe symptoms and malabsorption in case for Giardia, but also can present with non-infectious complication like autoimmunity and maybe even non-specific inflammation and colitis. We don't need to go over the genetic causes of common variable immune deficiency, but you need to know that common variable immune deficiency is characterized by dysfunctional humoral immunity with low B lymphocyte, hypogam, and impaired antibody response. With regard to the manifestation might be wide spectrum, including GI and non-GI, as I have mentioned before. But the GI is part of the significant manifestation of patients with common variable immune deficiency. If we delineate the manifestation according to the segment of the gastrointestinal tract, you can see some of the manifestation related to the proximal GI tract, like for example, fungal infection. Those patients can have neutropenia, therefore they can predispose them to fungal infection, especially if it is concurrent with prolonged antibiotic treatment. The esophageal candidiasis, as mentioned, is common manifestation in those patients. Atrophic gastritis and echlorohydria can manifest in good number of patients. 50% of common variable can be associated with reduced gastrin. They can manifest again with pernicious anemia-like manifestation, part of their autoimmune manifestation. Disease-related and manifestation related to the small intestine. Chronic diarrhea that can be caused by different reasons, different factors. Celiac screw-like disorder can be Giardia infection, bacterial overgrowth, and small bowel lymphoma. The other manifestation, patient with common variable in the small intestine can present with autoimmune enteropathy, which is mainly autoantibody against the enterocyte. And finally, nodular lymphoid hyperplasia is a special entity with multiple polyps or nodules in the small intestine. For the large intestine, they can present with IBD-like manifestation that can mimic ulcerative colitis and Crohn's disease. You can see in the biopsy T cell it can be caused by T cell defect and autoimmune phenomenon, but you can see at the biopsy and histopathological finding lymphocyte macrophage inflammatory infiltration with the apoptosis of expression. The granuloma and giant cell are usually absent in those patients, which can make it different than the typical IBD. Malignancy is the last type of manifestation or mechanism of manifestation of patients with common variable, and gastric adenocarcinoma are patients with common variable immune deficiency are at a higher risk to develop gastric adenocarcinoma, almost 50-fold increase. And probably the cause for this is the multiple factors, including echlorohydria, intestinal metaplasia, and pernicious anemia. The other malignancy that might be predisposed to is B-cell immunophenotype lymphoma, which can be triggered by Epstein-Barr virus, which is almost carry 3 times higher risk than the general population. So you can see that the common variable is, I give the example, common variable immune deficiency, CGD, are classical example of patient presenting with GI manifestation. There are some similarity and dissimilarity between patients with common variable enteropathy and IBD. You can see, for example, that there are low IL-17, IL-23, and TNF-alpha in patients with common variable. However, they are overexpressed and increased in patients with IBD. However, there are some similarity among both. For example, IL-12 and interferon gamma are increased. The manifestation might be common. But again, those patients with common variable immune deficiency not necessary to respond to the regular and conventional therapy that patient can be applied for patients with IBD, and patient might respond to them. If you look at, for example, the difference between common variable enteropathy and celiac disease, you can see again there are some similarity and there is some dissimilarity, but it can be also there is association between common variable immune deficiency and celiac-like or celiac disease. But usually patients with common variable immune deficiency enteropathy might have definitely will not respond to gluten-free diet, but they might also have difficulty to respond to the regular therapy. Patient with common variable immune deficiency with colitis, they have typical manifestation, but mainly that can have absence of plasma cells and giant granuloma. The giant granuloma are typical in those patients. And you can see also crypt damage in those patients if you go with more higher power field. The other entity of disease, the Igm syndrome, which is it's isotype switching defect. So patient will not be able to switch to other immunoglobulin like IgG, IgA, IgE. Therefore, those patients might be also having manifestation related to their disease pathology and pathophysiology. We do see a good number of patients with GI manifestation. If you look at the pure GI manifestation to patients with the hyper IgM, you can see oral ulcer, gingivitis, and rectal ulcer. Those patients have commonly neutropenia, and that might be contributing to these ulcers in the oral cavity. Protracted diarrhea, 50% of the patient, mostly due to infection with Cryptosporidium, Giardia, Salmonella, and Entamoeba histolytica. Other manifestation including liver involvement, and typically those patients, if they have long-lasting infection, they might present with severe sclerosing cholangitis. We know that sclerosing cholangitis is quite rare in children. However, 10% of the sclerosing cholangitis are more often associated with primary immune deficiency, typically hyper IgM. It might progress to fibrosis, which can lead to liver failure. It has been associated and linked with cryptococcal parvum as the most common pathogen involved in patients with sclerosing cholangitis. Finally, malignancy with long-lasting sclerosing cholangitis. Patient might have biliary tract carcinoma, which has been linked to Cryptosporidium infection, but also the other malignancy can be caused by hepatitis B, C, CMV infection, which also can progress to hepatocellular carcinoma. They have more tendency than other normal population. Presence of malignancy in those type of patients carry, as we know, that poor and guarded prognosis. Special disease entity like IPICs, which stand for immune dysregulation, polydendropathy, enteropathy, and X-linked syndrome, where there is a problem in the FOXP3 mutation, which is important for the function of T regulatory cells. If this gene is mutant and Treg is not functioning very well, so patient might be predisposed to infection in one side, but also can be predisposed to different type of autoimmunity and dysregulated inflammation. That infection typically is Enterococcus, but also can be Staphylococcus. Diarrhea is almost 100% there. So it has been reported almost in all cases. So the clinical triad is enteropathy, endocrinopathy, and dermatitis. They do have skin manifestation. Now the genetic diagnosis is available, so we have the privilege to make the diagnosis genetically, and the patient usually respond to immunosuppression with FK506 or cyclosporine. But most patients that they will require hematobiotic stem cell transplantation or gene therapy.
Rob, if you allow me, 2 minutes left.
Sure, almost closing. So the IPICs and other entity are under the category of what we call very early onset IBD, which is being diagnosed in patients less than 6 years, which represent 15% of IBD pediatric patients. It is a specific and significant IBD phenotype with severe clinical disease, usually does not respond to conventional therapy that can be used and applied for patients with IBD. Mainly, it's been associated mainly with monogenic. So it is a monogenic disorder and can manifest with different type of manifestation, including the IBD-like, like nail hair abnormalities, epidermolysis bullosa, and autoimmune hemolytic anemia. Firstly described in patients with genetic defect in altin cytokines and altin receptor, A and B. With the advanced molecular diagnosis, more than 50 gene and pathways has been associated with very early onset IBD. Here that can show you that is really, the list is being piling up, but definitely that looking at the altin, which is being described initially, that it is clearly can be, and we have found patients in Saudi Arabia with IBD related to altin and altin receptor. Many other genes have been linked and associated to this. And just to conclude with this slide, so as you can realize and recognize that PID have variety of manifestation, some of which involve GI and hepatobiliary system. It can be related to infectious and non-infectious complication, and they are high. They pose and they carry high risk of morbidity and might even sometimes mortality in among PID patients. Definitely, the mission of this webinar, for example, is to disseminate the knowledge, because early diagnosis of those patients with accompanied GI and hepatic complication can improve their quality of life and allow for appropriate treatment on time. I think we need in Saudi Arabia multidisciplinary clinical studies to evaluate the preventive and therapeutic modalities of patients with PID and associated GI manifestation. And thank you very much.
Thank you, Bro, for this nice and very informative lecture. And if you allow me to receive one question from Dr. Fahad Al-Harbi. Are you with me, Dr. Fahad?
Dr. Fahad, the mic is yours if you have any question or comment. There is 2 questions, Dr. Muhammad, في ال Q&A.
طيب, there is a question, Prof, with IgA deficiency patient, diarrhea, and recurrent infections. Any rule for antibiotic prophylaxis, and what's your advice?
As mentioned, those patients might be predisposed to infectious complication. I think the selective IgA deficiency are mostly asymptomatic. And if they come to the clinic with symptoms, I'd like to make sure they're really selective IgA deficiency, because as you know, it's a spectrum of disease between selective IgA deficiency and common variable. So you need to follow your patient and make sure that, refer him to immunologist and make sure that it's really a selective IgA deficiency. If you have, for example, just only diarrhea and you could not isolate any organism, I think it will be difficult to keep patient on therapeutic. However, prophylactic antibiotic have been tried in those patients.
The next question, Prof, if you allow me, is it harmful to start patient with CGD and with as a case of any IBD with biologic or immunomodulator as a bridge therapy to control the colitis, waiting for BMT, for example?
That have been tried, and this is the best. This is the only option that we do have. There are people who are concerned about, for example, patients with CGD. If you use biologics, and maybe I think Dr. Muhammad is going to talk about the therapeutic modalities in patients with GI and primary immunodeficiency. I don't want to take over his part. People were having concern, however, that we have tried it. There are other studies have been conducting the biologics in patients with CGD and other immune deficiency without major concern. The problem, even with the transplantation, those patients carry higher risk of severe GVHD of the gut. So definitely you need to control their colitis before you take them to bone marrow transplantation.
Maybe because of short of time, already we are 5 minutes, we want like to thank Prof. Saleh Al-Mohsen for nice and very informative lecture. Sorry for disturbing you, and you were busy, and you allowed us and to give us this appointment with you today.
It's my pleasure and my honor, Mohammed.
Thank you, Prof.
Thank you.
So we'll move to the next speaker, Dr. Mohammed Al-Usaimi. And he will talk to us about the updates of the immunotherapy, the pediatric gastrointestinal disease. And Dr. Mohammed Al-Usaimi is pediatric assistant professor of pediatrics in King Saud University, and also consultant of pediatric allergy immunology, and he is the director of the core laboratory in King Saud University Medical City, and he has many publications, and we have the pleasure to invite him and to hear from him today. The mic is yours, Dr. Mohammed.
بسم الله الرحمن الرحيم. يعطيك العافية دكتور محمد. سعيد بالمشاركة في هذا الويبينار, and I thank the organizer for this commendable organization of this in advance, mashallah, يعني line of communication and choosing the speakers and also the topics. I would like to talk about something that it's hard for clinical immunologists to talk about, which is immune therapy in a specialized system. We like to usually, as an immunologist, talk about immunology as a whole, and when we go into deep in a specific system, we really struggle, and will try my best to answer some of the immune aspect of pediatric GI diseases. I'm glad that Prof. Al-Mohsen and Prof. Al-Angari talked about from an primary immune perspective. I will try to talk about from a basic immunology perspective of a common GI diseases as well as primary immune deficiency. I have nothing to disclose. So my objective for this talk is to talk about first, the overview of the major pathway of the immune system, regardless of the primary immune deficiency aspect. We'll talk about biologics in GI diseases, and especially in IBD. We'll touch on the hematobiotic stem cell transplantation option for GI diseases. We'll a little bit talk about novel immune therapies for celiac disease and update in their upcoming research in celiac disease management. And then touch lately at the end about precision medicine and what is the future of the healthcare system in general and immunology in specific in managing diseases. So as Prof. Al-Angari and Prof. Al-Mohsen talked to you about, the major immune pathway or lines of the immune system is innate and adaptive. I kind of separated the physical and the chemical barrier from the innate response because it has a significant role in the GI system. So we'll talk about a little bit about the physical chemical barrier and then the specific innate immune response and the specific adaptive response. And from there, we go into the specific detail of each pathway. The physical, the chemical barriers, there is a lot of function in that, it's in the GI tract. One of the examples is in the first line of defense is the intestinal epithelial cells, which has a very tight junction and secrete a lot of mucus to help keep a layer between the pathogens and the immune and the whole body that and the immune system beneath the epithelial surfaces. And there is also within that tight junction, there is certain cells, M cells and dendritic cells has some sampling ability and kind of sense any antigen in the lumen and try to pick it out. Another cells, specialized cells in the GI tract is the Paneth cells, which produce defensin, which is another molecule that has an anti-inflammatory and anti-pathogen property. We also know about the secretory IgA. IgA is the most abundant immunoglobulin in the body. Although not in the blood, but in the body as a whole, it's the most abundant one, and mainly in the GI tract and the respiratory tract. And the purpose of secreting this IgA is to neutralize the microbe and try to reduce the load of pathogen throughout the GI tract. The innate and the adaptive response is they are not really, when we think about it from an immune perspective, the classification just for understanding and simplicity, but they really work together hand in hand. So once you finish from the epithelial surface and the physical barrier, you go into a special cells that recognize these danger signals non-specifically, which is the innate cells. You have the neutrophil, granulocyte, and in the gut, mainly the dendritic cells, the macrophages, and the monocyte that will play a major role in initiation of inflammation. And then you have the second layer, which has a more specific and targeted response, which is the adaptive immunity. And there is always a talk between the innate and the adaptive immunity throughout the immune response process. And the adaptive immunity, like the classical one, is the lymphocyte. You have the T lymphocyte, B cell lymphocyte, and the T lymphocyte, you have certain subtypes that recognize or respond to certain element of antigen, the Th1, the Th2, and the Th17. That's the commonest three that we know so far. In general, this is just a schematic. I will go a little bit in detail because once you understand this schematic, you will be able to understand the biologics and why these biologics is tried in IBDs. As IBD models, you have the genetic factors. Some of them has a tendency to develop autoimmunity in general and IBD in specific. And then you have the microbiota or the dysbiosis, the alteration of your commensal bacteria, and then the environmental factors. And when you have that factors, initiating factor and led to an impaired barrier function, then you'll have an activation of your first line of immune response, is the innate system. And here is the most significant cells, is the DC and the macrophages, and innate lymphoid cells that is now being heavily studied recently over the last decade. They secrete mainly a pro-inflammatory cytokines. The main one is the IL-6 and the TNF-alpha. And these will direct the adaptive immunity in form of the lymphocytes. So the lymphocyte, as I said before, there's Th1 site directed response, Th2 and Th17. And the commonest or the main player in the adaptive immune system in the IBD is the Th1 and Th17. And in order for the lymphocyte to go into the Th1 or Th17, you need to have certain cytokines that play a key role in differentiating these lymphocytes. So in the Th1 is the IL-12 and the IL-27, and they produce, as you could see, they augment kind of the inflammation, the interferon gamma, TNF-alpha, and IL-2. The Th17 in the lower, and the purple and the pink one, they secrete IL-17 and IL-21 and IL-22, and they are very, very important in maintaining the homeostasis of the epithelial cells, as well as reacting to the fungi and the early bacterial invasion. And then you'll have your background is the B cells, which produce mainly IgA here in the gut, and also another cells that is still having a lot of debate and about the role in IBD is the T regulatory cell. So the T regulatory cell comes later in the inflammation to help suppress the unwanted inflammation. And you could see in the lower part of the diagram is the blood vessels. So when you secrete these all cytokines and chemokines, the leukocyte will go from the bloodstream and the lymphoid organ to the lymphatic vessels to the epithelial and the subepithelial area. And you need a chemokine and also an integrin or adhesion molecule for these cells to recognize where to go and to migrate through the blood vessels. So the commonest one that in the GI tract is the MADCAM1 and the alpha-4 beta-7 integrin. So the integrin will interact with MADCAM1 in the endothelial cells and help migrate these cells, the lymphocyte, into the subepithelial layer in the gut. In terms of biologics in IBD disease, there's already approved like four classes that already approved and 3 or 4 under investigation. The commonest one is, you all know, the anti-TNF pathways, biologics, anti-integrin, and the anti-IL-12 23 axis pathway, and then the first generation non-specific JAK inhibitor. They're still under investigation. Some of them are in the phase 3 trials, some of them in the phase 2, is a specific JAK inhibitors that selectively inhibit some of the JAK, not all the JAKs. And also in that axis, the IL-12 and 23, specifically selecting the IL-23 because it has a more direct role in the IBD pathogenesis. S1P is another molecule that modulates the lymphatic lymphocytes moving from the lymph node to the site of the tissue. Is similar to the integrin role, is blocking the lymphocyte entry to the tissue. TNF, anti-TNF. TNF is one of the strongest cytokines available in the biology. As you could see, it does have a huge effect, not in the immune cells, but in many cell types in the body. It's one of the acute phase reactant. So I'll focus on the immune aspect of it. So when you produce TNF alpha, you have a strong Th1 response and the T cell proliferation to direct them to a Th1 response pathway. And also you will increase the IgA production by B cells as a whole in the blood and the mucosal surface. You will increase the fibroblast killing, and you will increase the fibrosis, you will increase a lot of inflammations. Endothelial cells will produce a lot of leaking and help leukocyte come to the tissue easily. So it's kind of like a powerful cytokine to increase inflammation unspecifically. The medication that's in the market, it's Influximab, which is the oldest one in the late 90s, I believe. Adalimumab and Golimumab, Citrozumab. Forgive me about the names. All of them sounds, it's very hard to pronounce. Influximab, and they differ between each other by the way they are manufactured. So Influximab has the Fab region, which is recognized the TNF as the mouse part, and then with the recombinant human FC portion. Adalimumab is a fully humanized monoclonal antibody. Golimumab, is not anti-TNF itself, it's anti-TNF receptors. And the Citrozumab doesn't have a Fab region, but have a polyethylene glycol attached to it. And they all function the same. They do have 3 different functions. One is neutralization of the TNF, soluble TNF, or by competitively inhibiting the interaction of TNF to the TNF receptors. They have a reverse, they call it reverse signaling, which help reducing inflammation and increase IL-10. and also help decreasing the Th1 polarization. And the last one is apoptosis of cells that deemed unrepairable by the NK cell pathway. The second class of biologics is the anti-integrin. And as I said before, the integrin that is specific to the gut is the alpha-1, alpha-4, beta-7. And the two that is FDA approved is natalizumab and vedolizumab. The natalizumab, as you could see here, has a dual effect that work on the alpha-4 beta-1 and the alpha-4 beta-7. And the alpha-4 beta-1 is usually in the brain. That's why it's used in the MS, multiple sclerosis. And vedolizumab is specifically targeted the interaction to the mid-cam1, which is specific to the gut. There is another one that is still in process, is the alpha-E beta-7, which is not targeting the integrin in the endothelial cells, targeting the integrin in the epithelial surface. So when the lymphocytes come from the endothelial surface and transmigrate to the tissue, in order for them to stay in the tissue, they usually use the E-cadherin and attached or be around the epithelial surface. So if you block that, even if they go into the tissue, they will not last long. That's the principle about this new anti-integrin that's coming into, I don't know when it will be FDA approved. The third axis is the IL-12 and IL-23. Why IL-12 and IL-23? Because they all share the same P40 subunit. So their receptors is comprised with two subunits. One is P40 and one is specific to each cytokine. And the one that is approved now is Usitisukumab, target the P40. So it target both cytokines. And I could see that the IL-12 cytokine mainly work on augmenting the Th1 interferon gamma pathway. IL-23 has a more role into the Th17 pathway. And Th17, it's more specific to the gut in terms of IBD processes than the IL-12. That's why now more and more biologics targeting that pathway and trying to be as specific as possible for lesser unwanted side effect. The fourth class is the JAK inhibitors, and JAK is kind of your main transducer of the signaling of all except the TNF cytokines that involve in the inflammation in the gut. So as you could see, the JAK we have in human JAK1, JAK2, JAK3, and TYK2 here. And each one of them has a specific attachment to a specific receptor of a cytokine. The main two JAK that is specific to the gut or pathology in IBD is JAK1 and JAK3. JAK2 is mainly in the hematobiotic pathway, and we really don't try to target them in the IBD medications. The beauty about these JAK inhibitors, they are oral route, and they are not a protein per se. They are a protein, but they are kind of, they have a lipid layer that is inhibiting them interacting with albumin or other proteins in the blood. And the reason why they need that lipid is because they are intracellular. They need to go into the cells to insert their effect. And the beauty about them, because if you have a patient with IBD and a very, the gut, the JAK inhibitor will not be affected, dosing of the JAK inhibitor will not be affected, and you will reach, they will reach the target. They are short half-life, but the problem with them is they have a very broad effects. That's why they are really selectively preserved for refractory IBDs, and hopefully by times we target a specific JAK inhibitor, they will be available for your first line or second line drug. And here's the status now in 2020. The only one that is FDA approved is the Tofacitinib. It's a JAK1 and JAK3 and TYK2. Mainly is JAK1 and then less likely JAK3. And then you have a specific one into the JAK1 and a specific one in TYK2. The only one is that gut specific is this trade name is TD14373. In summary, this is a very nice summary of what has been approved, what is under investigation, what is controversial, or what has failed. And you could see that in the TNF, most of them has approved and has a strong effect. And the approved one also the IL-12, IL-23 pathway, the Vidrozumab for the integrin, and the JAK inhibitors. Interestingly, the IL-17 pathway or the IL-17 biologic has failed in IBD compared to the IL-23. So to me, it sounds that the IL-23 is upstream of the Th17. So if you block the IL-23, you may have a favorable outcome compared if you block just the Th17. Second part of my talk about third part of my talk about hematobiotic stem cell for IBD diseases, and here I could there's two kind of area I want to talk about. One is the very early onset IBD with monogenic diseases identified, which is a straightforward the hematobiotic stem cell transplant usually preferred except for certain genes. And the second part, which is more controversial, is the refractory IBD. And if you have a patient who failed multiple biologics, what to do with them. And I don't want to talk, spend a lot because Professor Mohsen talked about early onset IBD. This is a very nice paper, came out a couple of months ago, looking at a large cohort of very early onset IBD patients. And you could see that most of them are less than 2 years of age, and quarter of them went to hematobiotic stem cells transplantation. Third of them had been in biologics, and this is their representations. And what is interestingly for me is the outcome of these therapy. So forget about the bowel surgery. I want to compare the biologics and the hematobiotic stem cell transplantation. So the third that has received some sort of biologics, only 25 of them has been effective, which tell you that people who have failed multiple biologics and they present early in life, they may have a severe phenotypes, and they may have a strong primary immunodeficiency cause to their IBD. For hematobiotic stem cell transplantation, that 70% of them has improved, 24% of them has failed, and which is for me, 70% success rate of hematobiotic stem cell transplantation is in the lower scale of other hematobiotic stem cell transplantation for other immune deficiency like SCID or combined immunodeficiency. But because the IBD is specific to the gut and immunity to the gut, there is many genes that is specific to the gut. And if you change the immune system, still the pathology in the gut or the problem in the gut doesn't go away. That's why one of the commonest genes that has failed the hematobiotic stem cell transplantation is the TTC7. which is a protein that's important in maintaining the integrity of the epithelial surfaces of the gut. So regardless if you treat if you change the the stem cells of the patient and the whole immune system, you will not be able to change the epithelial surfaces. So that's why they failed, and it's not recommended for those patients to have a hematobiotic stem cell transplantation. The same as for NEMO, because it's not just an immune defect, it's also an immune and ectodermal dysplasia or other outside immune defect that you cannot change with hematobiotic stem cell transplantation. And this is where the condition that is amenable and effective in for intestinal disease, the IL-10, Ibex, Westcott, maniform SCID, CD40 ligand, and SIAP. The one that is very hard to recover after transplant is the one that is specific to the gut or has other manifestation other than the immune defect or immune system defect. As you know, the process of hematobiotic stem cell transplantation.
You know me, 3 minutes left.
All right, is to have a donor that is as close as possible to the patient, and to collect the blood and then freeze them, and then do a conditioning, specific conditioning for this patient, depend on the genes, and then reinfuse that blood and try to provide supportive therapy till the hematobiotic stem cell engraft. The other part, which is the controversial one, is what about stem cell transplantation in your regular IBDs? Initially there was a few reports here and there which showed a huge promise about most of them has sustained remissions, but then there is a big trials in the Europe that has concluded in 2016, I believe, showed that hematobiotic stem cell transplantation did not improve IBDs, and the conclusion from that trials was they don't recommend hematobiotic stem cell transplantation for those patients. The last one, celiac diseases. The main treatment stay is to avoid gluten, but there is other investigation that is undergoing. One is to decrease the immunogenic epitope in the gluten by either genetically modify the wheat or try to do a mixture of enzyme that digest the gluten before it reaches to the intestinal epithelium to a very small fragment for the immune system to interact with, or to try to sequester the gluten in the epitope in the intraluminary by polymer or antibodies, or trying to prevent the uptake by improving the tight junction. And there is one medication that now is the phase 3 trials. And the last one is trying to prevent, and the last resort is the downstream immune activation of the gluten exposure. And lastly, 2 minutes or 1 minute, 1.5 minutes about the concept of precision medicine, and which is an emerging concept about treatments and prevention of diseases that take in account a lifestyle of each person. And I want to go back a little bit about how the healthcare evolved. So beginning, it was an individualized description about a certain phenotype, and then a group of population that share similar phenotype. And then we went to evidence-based comparing both group. And then now we are going to the era of back to the personalized medicine, but with more data. And the reason why that, because there's a lot of different outcome from disease through medication in patients. So patients vary in their symptoms, they respond differently to medical intervention, and some of them will have, you cannot predict their disease outcome. And we are really in terms of progress as a healthcare system, we're really lacking the progress in terms of response to treatment. So the antidepressant medication, for example, 38% of population will not respond to it. Asthma drug is 40%. Cancer drug is up to 75% will not respond to cancer drug. And why we now talk about precision medicine? Because we do have a DNA sequence technology. We have a powerful computer now. We have the AI coming back, coming soon. And we do have a huge biological data from the boom in the literature over the last 30 years. And the trend now in the precision medicine, usually in the genetic data, biobanking, pharmacogenetics, and big data and machine learning, and trying to predict which patient respond to certain type of medications. And there is a number of examples of how the benefit of precision medicine. I don't want to go into detail, but I want to go into one example of the GI. And the obstacle usually, because we don't have a strong research support, and most of our education in the healthcare system is not geared toward these advances in science. We're really lacking as a physician to understand these concepts and apply these data in a meaningful way. I will give you an example about a study that looked at the lifestyle modification and diabetes and blood sugar. So they try to give the patient a log of their food intake, and they measure their blood sugar while after each meal and before activity and after activity. And they have two tracks. One is a computer that will detect which diet that will lead to a reduced blood sugar in the blood. And it showed that the customized diet include the computer generated more information than a human could generate, and has more effective in controlling blood sugar. At the same time, it gave more, the customized diet include things that the patient like rather than what the physician wants the patient to be in. And in IBD in general, now you have this big data and we don't know what about them. From a genome perspective, to the exome, to the microbiome in the gut, to the immune data we have, or the information we have from the labs. And then we do have this question that we want to answer ourselves associated with disease course, disease susceptibility, disease outcome, treatment efficacy, treatment failure. As a human, it's really hard to combine all of these factors and have a predictive model. That's why the concept of precision medicine is coming into more and more of in the mainstream clinical research. And I hope, inshallah, within the next decade or so, we will be able to give patients personalized medicine that is more effective for each individual person. Thank you very much.
Thank you, Dr. Muhammad, for the nice lecture and nice ending and personalized medicine. And I would like to invite you, Dr. Muhammad, and Prof. Abdullah, if you allow me, to the stage of a few questions, if you allow me to come to this for this stage of any virtual stage, not the real stage. So the first, are we ready, Dr. Dhafar? We can ask the questions. First question for Prof. Abdullah Angri from Dr. Tawfiq Lawati. How to decide which best modality of therapy in children with Hermansky, IPEX, Wiskott-Aldrich, or other primary immunodeficiency enteropathy?
Basically, those conditions are treated mainly with bone marrow transplantation because of their, not because of the GI per se, but because of their overall, complications. I think for such conditions, the best thing, for which I would advise my colleagues in gastroenterology, is to just be able to recognize these conditions and the possibility that their patient might have an underlying defect in the immune system, so that they can refer the patient early into a clinical immunologist to, help in investigating and treating those patients. I think this would be probably the best thing to do, and then we'll take it from there.
And the next question for Dr. Mohammed. He's thanking first of all for this seminar, and he's asking about a case. It's a long case scenario.
Yes, I'm trying to read it. Yes. Yeah.
Okay. TTC 7A deficiency, amphilocerebrated, and UNTBN, and IVIG, and planned for bone marrow transplant. And as per your lecture, maybe it's not that much effective, if I remember
Yes.
well.
Yes.
And started on Influximab for IBD. Then they thinking about gastric outlet obstruction, gastrostomy. Not sure about absorption. Two questions regarding the oral antibiotics. The second question for the autosomal recessive. Is it okay to take it bone marrow from the parents since it's autosomal recessive in such case or not?
For the TTC
7A.
So for TTC 7A, like the current recommendation, the bone marrow transplant would only correct the immune defect that they do have. So some of those patients will have hypogam, some of them will have some of them will even have a cellular component, T-cell component, and that will correct it. But for the GI manifestation and the enteropathy, and I don't think it will correct itself. The literature, to my knowledge, is only 6 or 7 patients who has been transplanted, and none of them had recovered from an IBD perspective. So I wouldn't go into that a risky hematobiotic stem cell transplantation with the goal of correcting the IBD or the GI manifestations. As for the treatments for trying to suppress the inflammation, it's really hard because this is where for primary immune deficiency is so rare that it's really hard to have a singular approach for them in terms of a modality, and also in terms of which one of these medication. We don't have the luxury that, okay, we have 10 patients with this arm and then the other with the other arm. So I would advise in general to go with the least amount of immune suppression possible, and then go escalate up and up. So let's say if it's in flare, you start with steroid and then you go up, and trying to avoid biologic as much as you can, because you don't want to, because they are dysregulated immune system, you don't want to add something that is so specific in terms of biologic that may lead to another things that harmful way. I rather have a generalized form of some immune suppression rather than specific one. And that's why steroids, sirolimus, tacro, MMF, your old school drugs, I would go with them. That's my advice about this.
Okay, the next part, it's about the donor. If the patient, it's autosomal recessive, is it okay for the parents to be a donor?
So the donor status always depend on the gene and also the HLA type. So the best option is match related donor. So and usually the father and the mother would not have a fully matched. So either sibling, or maybe if they are really highly consanguineous, ممكن شو اسمه ولد عم أو ولد خال. لكن as a father and mother, they called haplo, which is less favorable than fully matched donor. So it's not about the disease itself; it's more about the HLA matching.
Okay. The last question maybe for Prof. Al-Angri. Would you do immune workup for a teenager girl who presented with disseminated visceral pyodermal gangrenosum involving the liver spleen without GI symptoms?
I think I'm not able to. Sorry, I think that would. Yes, that would depend on what we suspect. If there is, like recurrent infections, yes, I would do immune, testing. It depends really what is what's in our differential diagnosis of pyoderma gangrenosum of the GI tract, which is something that I may not be, I'm not really familiar with, but probably you guys are more familiar with. If there is among the causes possible immune defect that might explain this, then yes, by all means, an immune investigation should be performed. Pyoderma gangrenosum, for example, in the skin, could be part of, an autoinflammatory condition, could be part of, as of course, all IBD, like Crohn's disease, and in cases where the family history, especially, is suggestive, genetic testing is probably more useful. Yeah, but this is what I can say. I'm sorry, I can't be very helpful in this situation.
Thank you, Prof. Abdullah, and thank you, Dr. Muhammad, and thank you for Prof. Salih Mohsen also, who left us because he has he was busy. And thank you for attendee. I would like to announce, as per Dr. Dhafar, and he one of the committee for organizing this third International Pediatric IBD conference that will be as a hybrid. So this is the code you can register from this code, and also we will have a link. Thank you for all.
بس كما دكتور معاذ تركي كيف حالك؟ How are you? Are you with us?
تمام يعطيك
السلام
العافية.
عليكم، كيف حالك؟
أهلا وسهلا. شكرا لكم حقيقة. We are so happy in such began tonight that we have our colleague from King Saud Medical City, King Khalid Hospital. شكرا دكتور عبد الله. I'm happy صراحة that we have seen you tonight with us. الله يجزاك خير. وبروف صالح والدكتور عصيمي، فألف شكر حقيقة. And this is part of حقيقة our changing يعني the variety of webinars, not everything just GI, immunodeficiency is part of the gastroenterology, and this is our plan for changing all the topics and new things. I'm happy that many people are sharing us tonight, and there are some feedback from them in private messages. They are happy that to hear from you. Really, we enjoy it. جزاك الله خير ابو عمر وجميع الزملاء الكرام، وساعه مباركه. جزاكم الله خير، الف شكر، في موازين حسناتكم ان شاء الله تعالى.
الله يجزاك.
الله يعافيك، شكرا جزيلا.
Thank you all. Thank you all.
يعطيكم العافيه.